In this presentation, I'll be talking about the Work Package 11 JRA activities with which we worked in collaboration with Technion University. So the focus of this presentation is developing conceptual business models within the healthcare sector. So when we look at healthcare requirements, you can see the red line. There's an increasing demand for various reasons, and we're now challenged in that governments have reduced funding. So we need innovation to reduce the gap between the cost that is increasing and also the funding that is diminishing. So we focused on a specific example for disruptive innovation where we looked at vScan, which is a ultrasound scanning device, and it looks at providing a mobile service where doctors are able to go to the patient, or rather than the static, large and expensive scanning devices that are typically in hospitals, these devices are much cheaper, something in the region of 4,000 euros, and they make it more accessible to have such scans earlier. So the aim for this deliverable was to design affordable business models for ultrasound procedures. So we focused on developing conceptual business models, and we followed the object process methodology that's been developed by Technion University. So some of the objectives involved developing an as-is for how ultrasound scanning is currently conducted in the UK. We then looked at developing some models that could be implemented. We also developed a cost-benefit analysis just to illustrate which conceptual models are more applicable and which would generate better reductions in cost and an improvement in patient experience. We also looked at validating the model so that we could make improvements from a visualization perspective. So in this presentation, I'll take you through the business models that were developed, the cost-benefit analysis tool, and the application of OPM and vivid OPM, which is more dynamic representation. I'll also take you through some feedback that we received and some current and future interests I'll end it with. So we followed a step-by-step process where we initially looked at literature. We talked to people, doctors in surgeries. We tried to understand what kind of knowledge they have about using such mobile scanning devices. We then moved on to developing the business models and developing a cost-benefit tool, which is Excel-based. And we also looked at how we can visualize this using OPM and vivid OPM, which then led to the validation and verification, which helped us to assess the outputs. So when I'm talking about business models, there's 4 angles to this. The first one is how much profit will it generate. The second thing is what is the value that is offered to the patient. So this refers to what products are used, what services are used. The third thing is how do we provide the processes, how do we define the processes that will enable us to deliver the value. And finally, resources, which is working in alignment with processes. It's looking at what kind of resources we will need to deliver the business models. So here's just an illustration of what the as-is looked like. So you can see there's the patient, there's the surgery, there's the hospital. So initially the patient would go to the surgery. They would get a time to meet the GP. They would come back potentially, and from here you can see there's 2 journeys from the home to the surgery, and this, if required, the GP will send the patient to the hospital. So in total, this represents quite a long process where until the radiologist, who is the person which analyzes the results from the scanning, until this person reports to the GP, it can take up to 17 days from the initial start to the final consultation. Also, the patient experiences some difficulties in terms of how much they need to travel. So in the case of UK, we realized that on average, traveling to the surgery isn't far, whereas hospitals can be something like 24 miles away. Also, we realized that there's a lot of touch points, so there's many sort of iterations until you get the results, and it's just a 20-minute analysis of the condition of the patient. So our target was looking at these measures and trying to reduce each one of these aspects through the business models that are to be developed. So here you can see that the patient experiences costs, complexity. In the traditional context, they've had to go to the hospital because these are big devices, expensive devices, which can't be moved, so they don't have a portable feature. Whereas the business models to be developed looked at reducing the cost, reducing complexity, and increasing mobility. So these were kind of the targets that we had. And the patient experience was defined from journey time. So here is the first business model that we came up with, and it looks at the GP using the V-scan to complete the scan at the surgery. So the focus was on the GP could potentially have the skills to do the scanning. But when we talked to GPs, we realized that not all GPs are able to use this device. So there's some level of training required, and this varies depending on the GP's experiences. But overall, the benefit here is there's a minimum process of contacts. So the patient just goes once to the surgery, and the surgery is close to their home. An additional benefit is there's no external resources required. So this refers to potentially a radiologist or a radiographer or the hospital itself getting involved. The second business model looks at the radiographer visiting the surgery, and this is typically 1 day a week. So here you can see the patient travels to the surgery 3 times, where firstly they come to get an appointment, then they meet the GP, then they potentially meet the radiographer who is in charge of scanning. Once that's conducted, you can see the data, the images are feeding to the radiologist, and this radiologist could be located anywhere, and they report back to the GP, and the patient has to receive that report from the GP. So the good thing with this model is that the GP doesn't get involved in the scanning process. They just feed back, and that they notify whether a scan is required. The third business model is the radiologist visits the surgery every week. So here it is assumed that the GP can do the scanning, but the radiologist will decide what the results are. So you can see here that the patient will visit the surgery twice. So initially they'll go and have an initial assessment, and then they'll meet the radiologist, which will report to them instantly. So the advantage here is they don't have a radiographer, but the GP has the skill to do the scanning. And another advantage is the patient doesn't have to travel as much as some of the other models. The fourth model that we considered is a mobile radiographer. So in this case, the radiographer will visit the patient at the home. So they will get the images and send them dynamically to the radiologist. So in this case, the radiologist will feed the results to the GP, and the patient will have to go to the surgery to get the results. So the advantage with this is the patient will notify when they are available, and the radiographer will visit them at their home. So these were four main models that we came up with. We came up with some other business models as well, but we realized that these weren't as likely to be applied, so I won't be presenting those. So the next step was, across these business models, which ones are viable, which ones could create financial benefits to surgeries, and which ones would be benefiting the patients. So for this, we developed an Excel-based tool. This is looking at how many patients will require scanning, what's the patient journey, what's the patient waiting time, and various assumptions on how long it takes to do the scanning. And we also collected data about how much it costs different types of specialists to do the scanning. So these were all based on real data from UK surgeries. We applied Monte Carlo simulation, which looks at inserting 3-point estimates, a minimum, maximum, most likely, to represent how many patients come per day, and you can see the input requirements there. We try to reflect how much it costs to conduct one scanning, and we compared this across the different business models. So we try to understand how much savings per year would be realized by applying each of these business models. From the patient side, we mainly looked at how long the journey is to have an assessment made, and we also looked at the waiting time. So any improvements in these aspects represented an improvement in the patient experience. And we compared across these different models. So here you can see some results. So there's 4 different business models where you can see that the GP completing the scan itself at the surgery generates the largest amount of savings, whereas a mobile radiographer actually increases the costs. The other 2 business model 3, visiting radiographer and visiting radiologist, generated lesser savings. Also, from the patient benefits side, the GP completing the scan shows much higher, better benefits. But the problem with that is there's a high level of training required, which the GPs are finding it hard to commit themselves. So the next point was, how can we build conceptual modeling languages to represent the information that I've just gone over? So here the key things are, it can improve the information, the business models, the way I presented them. It can improve from them by showing more detailed interactions. It can help with enhancing understanding, and conceptual modeling languages can also make it easier for learning and implementation aspects. It is also possible to build dynamic visualization. So this means that you can simulate the potential movements and the potential sort of interactions across different elements. Now, when we look at conceptual modeling languages, there are many established approaches, but what we realized is that you have to be quite familiar with each one of these areas, and they're not always very expressive. So you might find it difficult to understand the low-level drivers. So based on this kind of background, we looked at object process methodology, which was developed by Technion University. On this slide, you can see there's three main aspects that are represented in this software tool. The first one is the large figure, which represents the different objects and resources and how these are interacting with one another. The advantage of applying object process methodology is that it tries to build a link between what are the objects and the processes, and it helps you to understand at a low level with different levels of detail the drivers. So you can see the OPD hierarchy explains, well, covers the different levels that you're representing, and the figure at the bottom right is representing the language used in this tool. So the target is really to provide a very simple, high-level demonstration of the business models in this case. So here you can see an OPM figure just representing our case. So we're looking at the patient, we're looking at the consultant, so the radiologist, and the patient is moving to the radiologist to understand whether they need a follow-up appointment, and the surgery receptionist is involved with setting the appointment. During this process, the target is to develop a report so you can have a final diagnosis, and this will be fed to the GP who stores the patient record. So here you can see there's the red dots show the different steps within each business model, and you can visualize how processes impact objects. So the target is really to understand how each of the steps are going to represent the whole model. So then we looked at how can we further enhance the OPM animation. So this is now looking at Vivid OPM, which is a visualization enhancement to OPM, where we're looking to represent through images the different types of objects, and we're trying to illustrate how processes are influencing the whole system. So in this chart you can see there's the patient, there's the radiologist, and this is the surgery, the GP. So initially there's the appointment setting, and the patient arrives at the surgery. So you can see the patient moved to the surgery, and we're now having the appointment setting, and we're realizing there's a need for scanning. So then the patient leaves the surgery, arrives back at home, and then comes back to the surgery for a scan. The image is created to represent the health, and then it goes to the radiologist. The radiologist does the analysis, and then this goes as a report to the GP. So then again there's an appointment that is set, and the patient needs to go back to the surgery to learn about the results of their test. So then they leave, and this is the vivid OPM illustration. So once we develop these OPM models and the vivid OPM, we went back for validation, and we talked to 3 different surgeries, and we received some feedback. So here's just to illustrate that the business models were discussed in terms of what the benefits were, what were the operational issues, and you can see the red one, the circle, which is radiologist visits the surgery each week, was considered the most applicable, easiest to apply, although it doesn't generate the highest sort of benefit from a financial perspective. So in the short term, this would be the easiest to apply. Some of the main reasons for this is because it's a quick process and you only outsource to one resource. So this means only the radiologist has to go to the surgery. From the validation for OPM, it was suggested that it's quite easy to understand what it is, and it's quite easy to develop it. But one suggestion was that you can't do any quantitative analysis with it. So it's very conceptual, and it's not possible to currently do any quantitative analysis. The vivid side, they suggested that the appearance wasn't friendly enough, and configuration wasn't very easy either. But they suggested that there were good things, such as it provides a high-level explanation to non-experts, and it's quite easy to understand each of the objects and processes involved in the system business models. Now I just want to move the discussion towards our current interests. Currently at Cranfield University we have the Through Life Engineering Services Center, which is built in collaboration with Bombardier, Rolls-Royce, BAE Systems and Ministry of Defense. And we've built a lab, and we're now starting to work on various visualization areas. So just to give you an example of the kind of areas we're working on, it's about building a national center for improving through life engineering services, and we've got various technologies that look at things like environmental test chamber, fault detection, so looking at no fault found, how we can diagnose that. Thermographic imaging is another area we're quite interested in. Virtual reality is an area we're trying to implement in healthcare. And also multi-touch table, which we've already applied, which I'll come to now. The virtual reality suit is a Siemens PLM, which is, we've mainly looked at how we can look at the engine, the different parts, and how we can design these different parts. So we've looked at it from that perspective, and now we're trying to understand whether we can improve, for instance, a 2D image that comes out from the V-scan and converts into a 3D, so that GPs, doctors can make more informed decisions. The multi-touch table, we've already implemented this, and we've looked at how we can actually enable the business models to be applied. So one example is the radiologist and radiographer, they need to communicate. So one is in the surgery, one is in the hospital, and we need to share very sensitive data, and we need to develop reports and analyze what the scan results are in a dynamic manner so they can communicate together. For this we used a program called MindMeister, which helps you to share any kind of images and share the OPM images, and we facilitated people to communicate one-to-one through this online meeting portal. Another thing about this is that you don't just need a multi-touch table, you can use iPads. So on one hand, the surface table is we considered as the assessment station, and there were many iPads that could log into this MindMeister facility to communicate and decide across different patients what the conditions were. So just to conclude, we see visualization as a key enabler to deliver healthcare outside of hospitals and to move it towards surgeries. OPM, we saw it as a useful tool to conceptualize quite complex and detailed aspects associated to the healthcare sector. Vivid OPM, we realized it as a beneficial tool, but it needs some improvements to represent the specific objects and the specific processes. And through validation and our ongoing communication with the surgeries here in the UK, there's still many more opportunities, and application of OPM is certainly helping to talk to policymakers and various communities in association. So thank you very much for listening.
Could you please explain us how your work for the 1000 scanner can be used in the visionary scope? I mean, for example, through OPM in TNA or other?
Okay. I think it's helping to develop how visualization could be applied. So potentially when you're designing what to visualize, what the system will be, what the results will be, you could initially start off by developing a conceptual map through OPM. So this could be relevant to every TNA project.
You talk about the business model. Is it possible, for example, that OPM can be used to modelize sustainability of visionary in a long-term view, I mean?
I think it can. Yes, it definitely can be. So for that, we could look at what are the different approaches we could apply, and this would help us to really understand what the targets are and how we're going to achieve it.